Thanks a lot, Kathy, and welcome everybody. So yeah, I'm going to give a brief update really of the pathway to trying to answer this question. This isn't work that I've done alone by any means. So colleagues in the University of Bristol, Jennifer Cooper, Rachel Denham, University of Cambridge, Samantha Ip and Spencer Keane, and from NHS Digital and from SAIL have all been instrumental, as well as everyone who's commented on the protocols and come up with ideas in CCU 002, many of whom are on the call. And what we sought to do, or what we are seeking to do, is to try and answer these two questions. What's the risk of a vascular event after SARS-CoV-2 infection? Whether that vascular event is a stroke, a myocardial infarction, arterial dissection or cardiac arrhythmia. And certainly we've seen in reports up till now, there's been a higher risk of venous events than arterial events, but we'd like to really quantify that risk in the whole population. And then put the risk after SARS-CoV-2 in context by looking at the hazards relative to SARS-CoV-2 after influenza or after other pneumonia. And if you like, that was the question we started with, but as Kathy said, with recent reports, which I'm going to come on to in a moment, we've had to pivot to thinking about the risk of thrombotic events after SARS-CoV-2 vaccination, where we're trying to repurpose our code and our phenotypes to look at, to answer the questions whether the risk of venous events is higher than arterial events and what the absolute risk of venous events is after SARS-CoV-2 vaccination and whether this differs by vaccine. So let's start off with where we started, which was thinking about the risk of these events after infection. Now this is clearly an important question. The higher the risk of any of events of different types, the more services are going to need to adapt to take account of this, adapting across the country. We're going to need to think about if the risk of vascular events is higher after SARS-CoV-2 infection, we want to know the time periods of that highest risk, and we want to know the magnitude of that risk to allow us to decide what level of action we need to take. And just to give you an idea, of course, part of the motivation for this was thinking about whether there were populations of people who were suitable for interventions or treatments, and some of that's gone away without that much knowledge of absolute risks. The two kinds of treatments that one would give to reduce the risk of ischemic stroke, venous thrombosis, pulmonary embolism, myocardial infarction are anticoagulants, so strong blood thinning agents, or antiplatelet, which reduce the ability of the platelets to coagulate in blood. So a bit of an update. Anticoagulation was thought of as a no-brainer to prevent the risk of pulmonary embolism in people admitted to the intensive care unit with severe coronavirus infection, but a recent trial suggests futility of that as an intervention, although there are other trials underway as well which are due to report. Aspirin is being evaluated, or has been evaluated in the recovery trial, which you'll all be familiar with, but those results aren't available for public consumption. So those results will be particularly interesting. So we're going to take, if you like, control of the epidemiological piece. What kind of conditions are we talking about? So let's think about a typical patient who's come to hospital with a vascular event after coronavirus infection. So here's a 70-year-old woman who presents to the emergency department with increasing cough and shortness of breath. She has chronic obstructive pulmonary disease, diabetes, and she's severely obese. And these comorbidities limit her to the ground floor of her home, and she's rarely outdoors. So she is a woman who is what we would classify as frail, or in some people call her multimorbid. And on arrival at hospital, she had a SARS-CoV-2 PCR and a diagnosis of COVID pneumonia was made. But 5 days after she was admitted to hospital, she didn't wake up one morning when she was being reviewed by nurses on her ward, and she was then seen by the medical team, who found severe right and right arm leg weakness. And we see on the right side of your screen, for those of you who aren't used to looking at this, as a CT scan of a patient's brain. And we can see the abnormal area here in the, I'm just going to get myself a pointer. We can see an abnormal area here in the top in the right side of her brain, an area of ischemic stroke, which has been due to an occlusion of one of the intracranial arteries, and we can compare that to normal. So this is a illness which is going to substantially increase her disability and reduce her chance of going home and living the life that she did before. The question that many doctors have and many patients is whether this illness is being caused by coronavirus infection, and whether this illness is more likely after coronavirus infection than after other infectious types. I think thinking about this epidemiologically, when we're looking at data available to us from the BHF Data Science Centre, determining cause really is going to be difficult. And our problems really are power. Post-coronavirus myocardial infarction or stroke are infrequent. So, for example, stroke occurs in 1 to 2% of people after COVID infection. Fortunately, in the BHF Data Science Centre, we've had a large amount of cases, so we probably will be able to overcome this, but any individual hospital-based cohort is going to have trouble in determining the answer to this question. There's going to be random list classification of events, both myocardial infarction or stroke particularly, which will reduce power, and that may be a problem for us in the BHF Data Science Centre. Confounding probably will be a problem. Patients who develop coronavirus infection are different from those who don't. We know that people who develop coronavirus infection are also at high risk of vascular diseases. Poverty, ethnicity, poor health and overcrowding form a nexus of exposures which are related together, and indeed some people can spend their whole career really examining how these relate to one another. And each of these is related to both coronavirus infection and to vascular diseases. And these are characteristics of individuals and characteristics of regions in which they live. And then there are time-changing confounders, so things that increase our risk of both coronavirus infection and myocardial infarction that change over time. So as we've looked over the course of the pandemic, in periods where people have been at particularly high risk of coronavirus infection, there may be reduction in hospitalizations. There may be some coincidence of higher coronavirus risk with periods of higher myocardial infarction and stroke risk, for example, during the winter. We might face problems of reverse causality. People who are admitted to hospital can acquire coronavirus infection during their stay, and so rather than the COVID causing a myocardial infarction or stroke, hospitalization with either of those illnesses might directly cause COVID. Selection bias, I'd hope, is not going to be too much of a problem when we're looking at the linked data sets that are available to us in the BHF Data Science Centre, where we have data linked between GP records, hospitalisation and death records across a whole population. But any hospital-only cohorts will run into this problem by selecting cohorts who are at higher risk of stroke and MI anyway, leading to the head-spinning problem of collider bias. And information biases, so our detection of COVID and our detection of myocardial infarction and stroke, might vary over the pandemic. As healthcare systems have become overwhelmed at periods, there may have been changes in coding, although on average it appears pretty good. But we might see some misclassification by COVID status, where people with symptoms after coronavirus infection are preferentially investigated or preferentially diagnosed when their symptoms. And these are just some of presumably a much, much longer list of things we're going to need to think about. So what population are we going to examine to try and answer this question? Well, we're fortunate our aim is really to look at the populations of England, Wales and Scotland who were registered with a general practitioner on the 1st of January 2020. And in England, that gives us almost the entire population, 54 million out of 56 million people. we're only excluding those who aren't registered with a general practitioner, or who or people who opt out, or their GPs opt out of the use of their data. So this reduces any chance of selecting a particularly high-risk population. We're looking at the entire population's risk. In Wales, the latest figure I was able to find, perhaps Sel colleagues can update us, there's a 79% population coverage in 3 million. And the advantage of using the whole population is that we'll do our best to avoid any selection and collider biases. And our original collider biases. Now, our original intent was to look at a disease-free population on the 1st of January 2020. That's to say, people who had had no risk of who had not had a previous myocardial infarction or stroke, to reduce the chance when we detected a new event in hospital records, to make us as certain as possible that that new event was really a new and incident event, rather than the chance recording of a historical event in coded data. I'm going to talk a bit about how we've changed that when we talk about some analyses with vaccines. The exposures we're interested in for this analysis is SARS CoV-2 infection. And when we're looking at this, I think it's important that we include people with a wide range of SARS CoV-2 severity. The advantage of looking across a whole population rather than a hospital-based cohort is we can get people all the way from people who've only got a positive test to people who are hospitalised and perhaps looked after on the intensive care unit with very severe illness. The other thing we wanted to make sure is that when we think someone has SARS-CoV-2 infection, they're very, very likely to have it, so that the test has a high positive predictive value. This is something that we probably need to think about in more detail. The figure here is the figures of people who've had a positive test over the course of the pandemic, which I've taken from our World in Data, where we've got population prevalences which they're very highest. They're about one in a thousand, but of course that varies very much over the country. And because testing, when we do a test, the chance of a positive test or the positive predictive value of a positive test varies by the population prevalence of a condition, we might find that the predictive value, positive predictive value of a positive coronavirus test varies over the course of the pandemic. So that's something we might need to consider, and hopefully we'll do that by taking into account time as one of our covariates. Our primary analysis will use positive SARS-CoV-2 PCR in Pillar 1 and Pillar 2 testing data sets, which really has the advantage for analysis that there's a great clarity in diagnosis and diagnosis date, but the potential disadvantages are the thing I alluded to, that there may be a changing positive predictive value of a positive test over that period. And our secondary exposure will be either a clinical either infection as identified by a positive PCR test, or an infection as identified by a clinical diagnosis. Now that's going to be much more important earlier in the pandemic, in April and March of 2020, when widespread testing wasn't available, in some cases even in hospitals. So to allow us to include those participants, that's going to be a much more inclusive definition. And within that, we'll be able to look at people who've only had a positive test, people who've had a test with a clinical diagnosis, and people who've had a clinical diagnosis only, which we'll look at in a number of sensitivity analyses. And what we aim to do is to, in our primary analysis, is to look at these arterial events. So an ischemic stroke, or a stroke of unknown type, or a myocardial infarction or retinal infarction, and venous events. So that's the first of a pulmonary embolism or deep vein thrombosis, or a cerebral sinus thrombosis. And in addition, we'll look at other vascular events that have been associated with COVID infection, so the myocarditis, an associated heart failure, cardiac arrhythmias, possibly major dissection of major arteries, and of angina. So that's a little bit about the population we're going to look at for this question, the major exposure, which is coronavirus infection, and the major outcomes we're going to examine. How are we going to analyse this? Well, there are two ways in which we could do this. The first of all is the self-control case series, which Samantha Ip has taken a lead on in this work package. Because our major problem is confounding, if we're able to compare the risk of events in an individual, we can reduce the risk of confounding by time non-varying factors. So just to put this analysis as simply as possible, if we have an individual patient at the study start time, what we're going to try and do is compare the risk. So we have a number of patients who, all of whom have both a coronavirus infection and a cardiovascular event. What we're going to try to do is, if we centre our analysis on the time of COVID infection, is it more likely that that stroke or heart attack occurred in a defined risk period, in our case a month after COVID infection? Is it more likely that that occurs in that risk period versus any other period in that person's follow-up? So this is a case-only design. Each person acts as their own control, and it does take account of time-invariant confounding. The problem about this analysis is it only gives us a relative incidence, and it doesn't take account of any time-varying confounding. And it does assume that if we've got our analysis centered on the incident or on the occurrence of COVID, it does assume that a myocardial infarction or a stroke or other vascular event could happen equally likely in control periods before or after the COVID infection. And the problem about that, of course, is that some people will have fatal COVID, and so they're unable to have a myocardial infarction after their event, and some people will have fatal cardiovascular disease. And the assumption that events don't influence the exposure or observation period may well be violated with this example. Although this analysis has been done a number of times by in a number of other severe illnesses, and it does seem that violating this assumption doesn't seem to be too important. So our analyses are very preliminary at the moment. So I'm going to share some analysis done by Fred Ho, Naveed Sattar, Jill Pell and others in Scotland. And our analyses look very similar to this. So to explain what we've got here along the x-axis of each of these graphs, we've got days from a positive test, and along the y-axis we've got the incident rates ratio relative to the control period. And if we take the example of myocardial infarction here, we can see that in the 5 days prior to the COVID infection, there's a roughly 5-fold increase in the relative incidence of myocardial infarction relative to the control period, and that's the same in the first week after coronavirus infection, but by the time one reaches 28 days after coronavirus infection, that's full to be the same as the control period. If we take the example of pulmonary embolism as a venous event, we can see here that the relative incidences both prior to the first week, during the first week and afterwards are much, much higher than myocardial infarction, and that's paralleled or mirrored in people with deep vein thrombosis. The confidence intervals here are relatively wide. So in this analysis there are roughly 1,500 COVID CHD pairs. So Samantha's looked in England, and we've got many more COVID CHD pairs, really more than 100,000. So the confidence intervals of our estimates are much, much narrower, but the general pattern of relative incidence is much the same. However, these analyses, in our kind of sensitivity analysis, the relative effect does seem to change quite a lot depending on the risk period, whether we choose 7 days or a month, and whether we exclude in-hospital events or not. The problem here, of course, is trying to deal with the fact that some people, to deal with the ordering of COVID and myocardial infarction within an admission. We only get discharge diagnosis with COVID and myocardial infarction or stroke on the discharge letter, and it's difficult to work out which has come first. And when you exclude those, these relative hazards reduce substantially. So, because that analysis is non-ideal but does deal with the problem of time invariant confounding, we've also got a cohort design which Jenny Cooper from the University of Bristol has been leading, where we look at the population who's registered with a general practitioner on the 1st of January 2020, and we've taken their follow-up period during, what we've done is looked at the follow-up period after COVID infection by weeks. And we're going to estimate their hazards relative to time not during post-COVID, by age, sex and time after COVID infection. What we found so far is that the relative hazards are very, very high within the first week or so, similarly to what we've seen in the self-control case series, almost certainly due to some selection biases in patients who are infected with coronavirus infection, but almost certainly as well there is a real and observed effect. So I'm afraid I haven't got any results to share with you, but we will share with you as soon as we've got them. So a couple of weeks, about a month or so ago, this question became almost the most relevant. What's the risk of a thrombotic event after SARS CoV-2 vaccination? So from our practice here in Edinburgh, I'll just give you an example of what happens in this condition. So this is a 55-year-old man who presented to one of our district general hospitals, who was very well, apart from ulcerative colitis. And 2 weeks after receiving the AZ COVID vaccination, he complained to his wife of a headache, and 2 days later collapsed with a very severe right-sided weakness, so he's unable to move his right arm or right leg. And on admission to hospital, he had the CT scan, which we see on the right of your screen, an intracranial, intracerebral hemorrhage. So as you can see on the left, the right side of this person's CT scan, there's a bleed into the brain. That's the white substance you see. And at the same time, he had the scan below. The scan below shows an occlusion of one of the veins that drains blood from the vein, from the brain, sorry, in his case, the superior sagittal sinus. And if one of the veins is blocked, you can imagine that the arteries continue to pump blood into the brain, and the blood is unable to leave the brain, and many small blood vessels can block. It can rupture, causing a bleed, and also there's a general increase in fluid within the brain or tissue, which can lead to brain swelling. This man deteriorated over really the next day to unconsciousness, and surprisingly for someone who'd had a clot, his platelet count, which are the small parts of the very small components of the blood which lead to blood clotting, were extremely low. And that proved to be due to an immune reaction, which I'm going to describe in a second. And he died 5 days later from this severe illness. So this is an important complication. So many of you will have read case reports in the New England Journal of Medicine of thrombosis and thrombocytopenia, which seems to occur in about a month after AstraZeneca vaccination. And these thrombotic events occur in unusual places. So for those who aren't used to working on the front door, working on the front door of the hospital, clots in the legs or lungs are your bread and butter. But these really are places that you would rarely see and unusual. So it's unusual to get a clot in the veins of the brain, and it's unusual to get clots in the portal vein, so that's the vein that drains the liver, the splanchnic veins, or those that drain the gut, or and the other hepatic veins. And most of these patients had antibodies to platelet factor 4. Platelet factor 4 is common after surgery or exposure to heparin, so in about somewhere between 15 to 50% of people after cardiac surgery. But it is present in these people after vaccination without exposure to heparin. And there have been several hundred cases of intracranial venous sinus thrombosis reported to the European Medicines Agency after vaccination, not only with the AstraZeneca vaccine, but also with Pfizer and Moderna, although the numbers are much, much fewer. So why is it important for us to answer this using these linked data sources? I think the important things we want to know is how common is severe thrombosis after vaccination for COVID. It's very likely from mid-March or now on, the increased surveillance for these conditions after vaccination will increase their prevalence. So what was their prevalence like, or sorry, what was the incidence like prior to mid-March? Now most doctors are being, or emergency departments, neurologists and others, are being encouraged to use the test to look at the occlusion of the intracerebral veins, and this test is not 100% by any means. It's quite a difficult test to do. It needs skilled radiographers, and it's a difficult test to interpret. Many people's veins have normal anatomical variation that can be interpreted as intracranial venous thrombosis. So how common is there any evidence that other venous events other than the unusual ones have been increased as well? And it's important to put any relative increase in intracranial venous thrombosis or anything else in the context of COVID, because these events seem to occur more commonly after coronavirus infection. So what's the balance of risk between the two? Again, observationally, in observational analysis, we do need to consider some important biases which are particularly related to vaccination. And so over the course of vaccination with coronavirus, of course, there's going to be confounding by indication. So those people who are vaccinated early tended to be people who are older and in more ill health. So there may be an apparent increase in the relative risk of heart attack or stroke in people who have been vaccinated because they are older or they have other illnesses. There may also be the bias of actually reduced incidence of heart attack or stroke as well, because there's good health. The people generally have good health at the time of vaccination. So what I've shown here in the figure is an example from vaccination after influenza. So here we've looked at the number along the x-axis. There's the number of weeks after vaccination, and along the y-axis is the percentage of people who died. Not percentage, I think it's numbers per 100,000 who died after vaccination. The dotted line is the population level mortality, and you can see that for most of these populations, very early on, within the first week, there is an apparent protective effect of reduced mortality in people who have had the flu vaccination, which doesn't seem plausible really. And it's very likely to be due to this effect of good health at the time of vaccination. So people who look as if they're going to die very soon, either they have advanced cancer, heart failure, or other things, will tend not to be vaccinated in many healthcare systems. And in flu, there was time varying confounding because a vaccination tended to occur before the flu season, and so there was an apparent reduction in deaths because things were happening outside of the flu season. So our current plan is to look at these events after vaccination, similar to our analysis after COVID, ischemic stroke, or other arterial thromboses, and to look particularly as to whether any of those arterial events were associated with thrombocytopenia. Now, in England, we don't have measured platelet count in the data sets, but that is available in Wales and in Scotland, and I know that analyses are underway to do that by Sale and colleagues in Scotland, and to do the same for venous events and to look at the occurrence of thrombocytopenia or this low platelet count. What we'll try and do is estimate the incidence of any event in the years prior to the coronavirus pandemic, 2018, 2019 and 2020, looking at any events that occurred in GP records, hospitalisation records or death records, and then to use our cohort design to estimate the incidence post-COVID from the from roughly January of last year to the beginning of vaccination, and then look at the incidence after vaccination, looking at the start of the vaccination program to really the latest data release, which is probably mid-March. And we'll look at age groups, people, different sexes, and people with and without a recorded thrombocytopenia in any hospital admission, and people with and without vascular disease by vaccine type and by COVID diagnosis type. So we've been very busy over the past few weeks trying to do these analyses, and we hope there are going to be some outputs coming out over the next few days, which first of all we'll share with people in HDR UK, CMO and collaborators on this call, and then prepare these for publication. We'll complete additional CCUO2 analyses, thinking about phenotypes that are not in our vaccine analyses, thinking a bit more about the self-control case series, which is an important, I think, very interesting epidemiological analysis despite its limitations, and do a comparison with other vaccines and other infections, aiming for these two outputs. So that's all I've got to say. Happy to answer any questions, and thanks for inviting me to speak.